untitled genes. So I'm going to tell you, one of the take-homes tonight is all cancer is genetic. That is not to say that all cancer is inherited. In fact, only a minority of cancers are inherited. So you can inherit alterations in these growth-regulating genes that put you at greater risk for developing a cancer. The story you've all heard, I think, in the lay press, certainly with BRCA, the BRCA gene in families that have a higher incidence of breast cancer than the general population. That's because those patients have inherited an alteration in some of the DNA repair processes, so they're at a much greater risk of developing a malignancy. But that's only a minority of patients that develop cancers. The majority develop it because of these mistakes that get made during the course of our life in various tissues. So another take-home is the longer you live, the more you're at risk, hence the numbers. So good news, challenging news. That's where we're at with regards to that part of it. Looking at this on the bottom panel, you can see you're going for mammals from a single cell to an organism in a period of a very short period of time, 9 months. But I hopefully convinced you that there's an enormous amount of growth that goes on after that as adult, all the way up to and through the point that we're no longer around. So it's a process, a very dynamic process. Now with regards to breast cancer, which we're going to focus on a little bit tonight, every woman in this room knows that the breast is a dynamic organ in the sense that premenopausally it changes monthly, and it changes with the menstrual cycle. And that's based on what happens in the breast to all these cells that are specialized to do what defines us as a species, produce milk as mammals. And what happens is if there's things that are getting ready for the possibility of fertilization and conception and fertilization, conception and an infant, there's proliferation of the cells in the breast. If a pregnancy doesn't happen, there's involution of those cells. They go back down in numbers, hence the change in size of the breast during the cycle. If a pregnancy does occur, there's a dramatic change in the breast in terms of proliferation of these cells. During lactation, there's even a further change in these cells. And when all of that's done, the process is shut off and the cells involute, and you have the cells going down in number. So again, this dynamic process. What's that process that gets broken in something that we know as breast cancer? And think about the other organs of the body, the turnover of the entire gastrointestinal tract. If mistakes are made in the wrong genes that are controlling the plenum, you have a colon cancer or rectal cancer. The same in the pancreas, the same in the bone marrow with leukemias, the same in the lymphatic tissue with lymphomas. So I think you get the picture at this point. This simply shows what happens in the cell division. You go from this blueprint that's sort of depicted by these light blue shadows in the middle, which are the chromosomes that line up. We have 23 from our paternal side, 23 from our maternal side. When they come together in fertilization, you have the 46 chromosomes that are the complement of a normal cell, and then it proliferates. And then remember what I said, now I'm becoming repetitious. Every time that cell divides, it has to copy all of that exactly correctly. And it does it again and again and passes it on to the daughter cells. So these genes that I'm telling you about, there's a series of genes that are accelerator genes, using now, switching the analogy to an automobile. Think about it as the accelerator, things that will make things go faster in cell growth. You need cells. The story I told you about the bone marrow producing white cells, the breast tissue producing cells in anticipation of a pregnancy and producing milk. These genes get turned on, and they're proliferating, the cells are proliferating, and what they are is growth factors or growth factor receptors, and they encode proteins. All these blueprint genes is just what the blueprint says. That's the DNA. The DNA is converted into an intermediary nucleic acid called RNA. The terms aren't important, but ultimately the DNA and the RNA gets converted into the action molecule, which is the protein that carries out the function. So think again by way of analogy, if you're thinking about a blueprint of your house, when it was built, there was little circles put in or squares put in where doors are supposed to be and windows are supposed to be. Well, the actual door and the actual window is the protein, the thing that actually carries out the function. That's what the accelerator genes are, and there are several different types. There are several hundred. We have a total of about 28,000 genes in our genome. There are several hundred, and in fact, now we know there are probably a few thousand of those that are involved in the growth regulation process. Some tangentially, some directly, and any of them can become broken if they're copied incorrectly. So the growth factors and the growth factor receptors. The growth factors and growth factor receptors are on the surface of the cell. The growth factor attaches to the receptor, and then the signal is passed sort of like a fire brigade from one molecule to the next, proteins that are pass the signal down to the nucleus to tell the cell to proliferate. And this is called the signal transduction pathway. And those things can become broken. And then when they hit the nucleus, they turn on a whole spectrum of genes that make proteins that allow the cell to divide. And there's a whole transcription process that are controlled by transcription factors. They can become mutated. So you can see there are several places where you can get an entree into a mistake that can cause a dysregulation of the accelerator. And stick the accelerator on, in the on position. In addition to the accelerator genes, there are brake genes. So we know, using the car analogy, there are genes that turn this process off. I told you about the bone marrow when the infection is cleared. We've talked about the breast when a pregnancy doesn't ensue. There's involution of the cells, or when lactation is done. And the genes that are involved in the growth suppressor genes, and they encode proteins that shut down this process. They also have a signaling pathway, and they also have transcription factors. So here's a whole other side of this process that can get broken. And in some tumors, the gas pedal gets stuck on and the brakes get broken. So you can imagine what happens in those tissues. It's runaway, dysregulated growth. So to the degree that if you think about cancer in any way, this is what's going on, and this is what I mean when I say all cancer is genetic. It's something that's broken in those genes that are regulating these processes. That is what's going on. Now, what we've done traditionally, and it has been effective for many, many patients, is throw in nonspecific bombs, hoping to kill more of these rapidly proliferating cells than normal cells that are also proliferating. Hence the side effects that patients are challenged with when they get treatment, and some of the things that Dr. Glaspie has worked on for a lot of his career to try to ameliorate by suppressing those things that hurt normal cells. So this turnover is continuing throughout our lives, and there are several processes that happen in each cell. Now, this is hopefully the most complicated cell slide I'll show you. There'll be a quiz at the end. So, but really, it's meant as a diagram that you don't have to take a lot away from, other than the fact that two really good scientists, Doug Hanahan and Bob Weinberg, back in 2001 wrote their first article called The Hallmarks of Cancer. And they looked at all the malignancies that occur in people and said, or in animals, and they said, here are the things that you always see in a cancer. And there's this proliferation, if I can find the pointer, here it is. Go back. Proliferation by growth signaling, the ability, it's somewhere here, I'm at a disadvantage in terms of the angle, but you can proliferate, turn on the accelerator, you can break the brakes, you can mess up the DNA repair pathway gene so that when a mistake is made, the cell can't repair it. You can turn on things that allow you to make blood vessels to support growth that's not supposed to be occurring. The other things, the other pathways that are important is there are adhesion molecules that are proteins that are made by genes that tell the cell where it's supposed to stay, and it's supposed to stay in its neighborhood and not move out of its organ and go to different things. So those get broken in cancer, hence the process we know as metastasis. So in breast cancer, you've heard some patients come in and say, well, I have breast cancer, and then maybe 2 years or 3 years later, they say, now I have bone cancer. And then they come back and say, now I have liver cancer. And you say, gee, that's a really unlucky person. What they really have is breast cancer that's moved outside the breast to establish itself in these other organs. And it's the establishment in these other organs that is generally what is the biggest challenge to the patient. Because after all, if breast cancer stayed in the breast for its entire time and didn't travel, just surgery alone should cure most of the patients. And that doesn't occur because these cells can travel outside. There are genes that regulate that. Well, in 2011, the only reason I put this slide up there is they went from 6 characteristics up to 10 characteristics. And these 10 characteristics are sort of depicted up there. But what we've learned is the genes that regulate each one of these characteristics, many of the genes, not all of them. So to Robbie's point, we haven't totally demystified, but we've demystified to a good degree, understanding what the genes and proteins are, and figured why not try to intercede there as opposed to throwing in a bomb, hoping to kill more bad cells than good cells, and do something that's more specific. Now, again, I have what hair is left, enough gray hair to remember this picture. I told you about growth factor receptors. So by way of analogy, this is what used to be, and the youngsters in the room won't remember, anybody younger than 40 probably won't remember what this is. It's a television antenna that used to sit on the roof of your house receiving signals from the outside. That's the growth factor receptor by analogy. The signal that came into the antenna is the growth factor, and then there was a wire that went from here down to your set. That's the signal transduction pathway. These are all molecules. This is a molecule. The growth factor itself is a molecule. Multiple molecules in the signaling pathway down to the nucleus, which was the television set where you got the signal and it got read. So again, anywhere along that pathway you can get these things that will be broken. Now, how do you use all this? Well, let's look first at what we've done traditionally. And the good news is the traditional therapeutic approaches has made a big impact in cancer in the sense that just over half of patients who are challenged with a really life-threatening malignancy at diagnosis can be cured of their disease. So that's great news. But that means that just under 50% don't do as well, and what are we doing for them? Now, the traditional approaches have been the following. Our surgical colleagues have the first crack at the tumor, and their objective is to cut it out, and cut it out its entirety and try to have the margins clear so you don't see any tumor cells at the resected site. So hence the thing that patients are frequently told, we got it all. Well, you got everything that you can see grossly, but remember the problem I've told you. These cells have defects in their ability to tell them to stay put. And so they move outside the primary tumor bed and travel to other parts of the body. Some of them can do that very early on without spreading to the lymph nodes, without spreading into the surrounding tissue. So the margin looks clear, but inside the tumor cells have had access to the vasculature that fed that tumor, and they have access to the lymphatics. So it can spread 2 different ways in addition by direct extension. So if the genes that regulate telling them that they're supposed to stay there are broken, which they frequently are, the tumor will travel. The surgeon cuts out everything that they can see. Our colleagues in radiation therapy, and you'll hear from Paul when we have the Q&A, are able to use ionizing radiation and other forms, not just external beam, but other forms like implants, to try and use ionizing radiation to kill those cells that are remaining and sterilize the field. And if the tumor is a particularly aggressive tumor that is at high risk to recur, meaning we think, even if we haven't seen them on our scans, that this is an aggressive tumor that is likely to send off cells into other organs, we give systemic therapy. And that systemic therapy is the traditional cytotoxics, chemotherapy, some hormonal therapies that have been used for certain cancers like prostate and breast cancer, and then the newer era of biologic therapies. And biologic therapies are those when we really have figured out what's broken, we can try and approach that directly.